episode in operative management of fractures. Before I continue, I would like to welcome you back. For those who are our subscribers, welcome. For those who are new, kindly subscribe and share and like our videos, and also hit the bell icon in order to get these videos and more. Thank you. So what is non-operative management of fractures? This is a conservative way of managing fractures without the need for surgery. So as we continue, how do you know that you need to manage this type of fracture non-operative or not non-operative? You have to classify them, and in classifying them you can classify into simple or compound. For those simple fractures are usually the ones that are closed. For compound fractures are the ones that are open. And to help you further know specifically the type and how and the ones to manage non-operatively, you use the AO classification, whereby you classify using the bone number, the part that is if it's at the proximal shaft or distal, you give them at the proximal is 1, shaft is 2, and distal is 3, and then you further classify them into simple, wedge, and compound. As for the simple, is usually given A, the wedge is given B, and the complex is given C. So we will move with the simple. From the simple A, it is further subdivided into subgroups of 3, which is A1, A2, and A3. A1 is usually spiral, A2 is oblique, and A3 is transverse. So for those simple, with the AO classifications are the ones that we manage non-operatively. Yes, so after you've already known that, we can further go, if you like, for B, which are wedge. You start with the B1, which is a spiral wedge. B2 is bending wedge, and then B3 is usually a compound wedge. And the complex, we have a spiral compound, that is C1, segmental, which is C2, and then C3, which is irregular. So after knowing the AO classification, and we've known that for the simple fractures are the ones that we manage non-operatively, we go to the principles of fracture management generally. So what are these principles? You use the advanced trauma life support, the ATLS protocol, which you can remember with the 4R, which is resuscitation, reduce, retain, and rehabilitate. So let's start with resuscitation. With the resuscitation, you look at the ABCDE, which is airway, breathing, circulation, disability, and exposure. So after resuscitating the patient and you've done all that, including the test, and you found the results, patient has a fracture, you move to now reduction. So in reduction, what do you do? For non-operative management fractures, we use local anesthesia, which is lignocaine, that usually, or an hematoma block, that has it's usually lignocaine with 2% of adrenaline to help ease that pain of reduction. So in reduction, we can say maybe some little steps on how you do reduction, of which after applying the hematoma block, you will follow by counter traction to disimpact the fragments, and then you bend to worsen the angulation, then you retract by applying traction, and then you do a 3-point mold to help reduce that fracture if it's slightly displaced. So after you've done that, you need to hold those fractures into place. What do you do next? You retain. So by retaining these fractures, you retain them by use of casts and splint, which brings us further to explaining the upper and lower limbs types of casts and splints. So for the upper limbs, we have different types of casts and splints depending with the different types of fractures and injuries. For example, there are some like U-slabs, coarctation splints, and sugar tongue, radiogata, ulnar, extension, body splinting. Yes, those are some of the examples that you can use for the upper limb. For the lower limb, we have things like Robert Jones, back slabs, circular, cylinder casts, and so on and so forth. Yes. So after you're done with retaining, go to rehabilitation. First, you have to advise this patient on the care and complications of casts or plaster of Paris in that case. So let's start with the care. So what is not supposed to touch or enter inside the cast after you have applied it, as this may cause some reactions. The patient is supposed to also exercise the limbs to help facilitate the circulation of blood into the fracture site to help speed up healing. They also need to advise on nutrition, that they increase the intake of calcium, or if not, you can prescribe for them these calcium supplements they take. And pain management is also important for us to manage that. And you need to use analgesia, opioid analgesia in fracture management, and not an NSAID, as NSAIDs usually inhibit prostaglandin, which is usually important in bone healing. So after advising patient that, and they're not supposed to put things inside the cast, as this may create no pressure and cuts and may lead to bleeding and infections. In case of any problem, they are usually advised to come back. So another thing that we're supposed to know is the danger signs after you've applied the cast. One, patient, you're supposed to advise the patient that they should always check and compare the normal and the one that is broken limb at the nail beds, to check the color. If it turns, it means there is impaired circulation, and this might bring gangrene. So it's important that they come back before the date that you wrote. And before I continue, it's important to do a 24-hour review system after you've done a cast, in order for you to capture any complication early and rectify them before it goes further. Another sign that we need to look for is the tingling. A patient can complain that they are numb, or they have some tingling sensation, or they can't feel their limb. That's another sign you should look for and advise this patient. You should also advise them to check if the limb is, swollen, as it may create more pressure and bring things like compartment syndrome. Yes, and that's it for today. Thank you, and subscribe, and next time we'll bring more details on specific fractures and how to manage them and classify them. Thank you. Until next time, bye.